But boom, we are now recording. Welcome to week 2. This week we're going to talk about blood and blood products. If it moves, keep an eye on this guy. There again, if you see him, you might see it somewhere else. What we're going to basically talk about is the basic blood products. Now, last week you learned about the CBC. You know about red blood cells, white blood cells, plasma, and platelets. Those are basically the four basic food groups. If you're a vampire, that's the 4 basic food groups. That's the 4 basic blood products. But we also have to talk a little bit about blood typing. You know, A positive, O negative, all that. It can be rather confusing, but I have a couple of rules that I think will help make it a lot more simpler for you. We're going to talk about how to administer blood products. That's very important because it's a rather intense process and you will be involved in it. So you really should kind of know the ins and outs of that. And also about the possible reactions you can have to blood products. I'm sure you've all heard of transfusion reaction. You know, somebody who's O positive gets B positive blood by accident and they have a reaction. I'll tell you how to deal with those. It doesn't really happen nowadays, mostly because the blood banks are very, very good at what they do. And the procedure that you as a nurse goes through before you give blood to the patient is rather intensive. So the idea of giving somebody the wrong blood is quite remote. It does not mean they cannot have a reaction, though. They can still have a reaction to other things. So what is blood? That gooey, nasty stuff you see in horror films. That's really not true. The stuff you see in horror films isn't real blood. It's just a dyed product. So that's not real blood. But as you learned last week, it consists of erythrocytes, which are RBCs, leukocytes, platelets, and plasma. We have each of those products in the blood bank, but there's a couple that we use more often than others. Rarely will you see us. In fact, I don't think they do a separate WBC component. That's usually we give them plasma, which contains the WBCs. So there won't be a separate WBC component. But there he is, popping up again. 2 most common products that we do give are packed red blood cells. And what we do there is when the centrifuge spun the blood down, separated the red blood cells, that's what they do at the blood bank. It only contains about 25% of the original plasma in it. So basically, we're just concentrating the red blood cells. And I'll explain why that is. And fresh frozen plasma, we use that a lot as well. And we'll talk about the other 2 that aren't so common. Of course, all this is given by IV, because you all know that. Ta-da, blood components. I should put a bugle in there or something. The most common thing that you will be doing as far as blood transfusion goes is packed red blood cells. When you see them run upstairs with that little plastic bag of blood, that's what it is. It's packed red blood cells. Then the reason we do that is normally when we're giving somebody a blood transfusion, we don't want to give them the whole blood product because we don't want to increase the volume of their blood. What we want to do is we want to increase the percentage of red blood cells that are in their bloodstream, because the red blood cells are the ones that are transmitting the oxygen. So we want to give them more of what they need without giving them more of what they don't need. So that way we can just give them some nice rich red blood cells without, overloading them volume wise. So that's why we use the packed red blood cells most often. We use those for people who had excessive blood loss. In other words, you're in a car accident, your legs split open, you're bleeding a lot, and you get into the ER, and first thing they do is they start giving you blood because your blood pressure is 70/40. They're going to patch you up as best they can, and they're going to give you blood to get your volume back up again. Now, there again, they may be giving you just packed red blood cells, but the initial thing we give you to increase your blood volume is normal saline. So you've probably already gotten several liters of normal saline before we start giving you the packed red blood cells. So we don't want to give you whole blood products because we don't want to, volume overload you. So, but that is one reason we do it. Anemia, and there's different types of anemia. I'll explain that next week. And kidney failure. Now, who can tell me why kidney failure will lead to anemia? We'll see who paid attention last week. Bueller?
Because
EPO, we already talked about that. I talked on last lecture too.
Now, you said EPO last week, Maya.
Yeah.
Yeah, you're absolutely correct. When your kidneys die, you're not producing EPO, which is a hormone that produces blood in the bones. So pretty much every person in kidney failure is going to be anemic. We try to fix that by giving them EPO first, but if it gets really bad, we may have to give them blood transfusion. We normally get it from volunteers. We all go to the blood bank. And like I said, only about 25% of the original plasma is still left in the red blood cells. It can't be 100% red blood cells because the red blood cells have to have some kind of liquid or medium to float around in, otherwise they just cluster together. As I've been saying, the reason that we give them packed red blood cells is we're not trying to increase their volume necessarily. We're trying to increase their oxygenation. So for every little packet, they're usually about 700 or 600 milliliters in those little packets. We'll increase their hematocrit by 2 to 3%. So if you have a hematocrit of 45, it'll push you up to 47. In order for us to give you this, you must be typed and crossed. Typed and crossed is the test, a lab sample that we send to the lab where they determine what your blood type is. So what's a blood type? Well, anybody out there not know what their blood type is? There are basically 4 types of blood types in the world. Type A, type B, type A and B, which is a combination of the two, and type O. For anybody who is interested and wants to learn more about that, a fascinating book came out several years ago called Eat Right for Your Type. I was going to look up the author, but I forgot. Eat Right for Your Type. And in that book, it's written by a naturopath who contends that it was our diet that caused our blood types to change. Now, for those of you who believe in evolution, we all started in Africa, and the most predominant blood type in Africa, or the original blood type, was O. And then as people migrated north into Europe and east toward Asia, they developed the A blood type and the B blood type based on changes in their diet. As they became more agricultural and ate more grains, they changed, and I can't remember what changed to what, but for example, their blood type would change to A. If they went east and, if they went up north and they raised more cattle, their blood type would change to a different type. I think going north into Europe was type A and going east toward Asia was type B. But as you head up toward Mongolia and they started eating more dairy, they developed the type AB. So it's fascinating. If you're curious about that, you can read that. But the basic rule there is you never mix the different types except for O, and we'll talk about that here in a second. There's also another thing to do with blood typing, and that's the Rh factor. The Rh factor, you either have it or you don't. If you have that Rh antibody on your blood, you are Rh positive. If you don't have that Rh factor on your blood, you are Rh negative. So Rh factor, you either have it or you don't have it. The important thing about that is you can't give somebody with an Rh positive to somebody who doesn't have the Rh factor, because your body will look at that Rh factor and go, invader, invader, and it will attack the blood, causing a transfusion reaction. I'm going to give you a couple rules here that will help you out on that. So as you can see, here is just the plain blood type compatibilities. And basically a good thing to remember is A get A, B get B, AB gets AB, and O's get O. But the exception to that is O's can go to anybody. So that is why O is that's why O is so wanted by the blood banks, because we can give O type blood to O person, A person, B person, or an AB person. If you look at that chart, you will also notice, yeah, that O can go to anybody. But A can get O, or A can get recipient. Oh, that's a recipient. This is the blood donor. Okay. O person can only get O. That's all that the O person can get. The A can get A or O. The B can get B or O. But the AB, he's got a combination of the two. So he can get O like everybody else can, but he can also get A, he can get B, and he can also get AB. So he gets all of it. Now, when we add the RH factor, it gets a little more confusing. And there, it's a lot easier if you don't try to memorize the whole chart. You just memorize a couple of rules, and I'll tell you what those are in a moment. But see, now when you add the RH positive, RH negative factor, it gets a lot more confusing. Here's a simple way to remember it. Basically, it's same to same. If you're A, you get A. If you're B, you get B. If you're O, you get O. If you want to remember that AB can also get A and B, you can. But if you ever have any question, this chart is always up in the nurse's station. You just go look it up. But I'll tell you, 99.9% of the time, when you get blood for a patient, it's either going to match the patient exactly. For example, your AB positive patient is going to get AB positive blood, or they're going to get O negative. You're going to get one or the other. Now, what's so wonderful, well, let me finish with that. So just remember that everybody can only get their similar blood type. A's can get A, B's can get B, but everybody can get O. O is a universal. Now, when you do the RH factor, the thing to remember, so they're same to same. The other rule to remember is RH, never give RH positive to an RH negative client. What will happen is the RH negative client, the body will see this RH positive antibody on the blood and think it's an invader and attack it, causing a transfusion reaction. Now, the RH positive patient can get RH negative blood. That's fine, because he's got an antibody on his blood, but the donor does not have that antibody. So the RH positive client doesn't have anything to attack on the donor. And if you look at this chart, you will see there that the RH positive, or say A positive client, can get A positive blood or A negative blood. Now, since he's got that positive RH factor, he can also get O positive blood, and anybody can get O negative. Clear as mud, right? Just remember that. In general, same to same, except for O. Anyone gets O, and never give positive to a negative client. As long as you keep those two rules in mind, they'll keep you out of trouble. Now, the reason that O goes to anybody, and if you don't have the RH factor, that means you can give that blood to an RH positive or an RH negative person. That means that O negative, my blood type, is a universal donor. O negative can go to anybody. And what's wonderful about that is ERs around the world will stock up on O negative blood and have it in the ER. Now, that way, when a patient comes in, they're knocked unconscious, they're bleeding profusely, and the doctor says he needs 2 liters of blood, they don't have to do a type and cross on the patient. They can take the O negative blood and just give it to them because they know there's not going to be any kind of reaction. So that's why you'll always see O negative being stocked in the ER. Are always available in the ER. And if they don't know the person's blood type for whatever reason, they will give the patient O negative. Now, on the flip side of that, AB positive, he can get A, he can get B, he can get O, he can get negative, he can get positive. So the AB positive person is a universal receiver. He can get any of the blood. And if you go back up here, you'll see that reflected in the chart. All the different recipients, they can all get O negative. And the AB recipient, he can receive anybody's blood. So you have the universal donor and you have the universal receiver. That's all you really need to know about blood typing. I'm not going to try to trick you with any questions on that on the exam. I might ask you though, okay, what is a universal donor? Or, you know, would you give this A positive blood to this A negative patient? But I'm not going to say, okay, you have O negative and an AB positive patient. Are they compatible? I'm not going to try to trick you on that. Does anybody have any question on blood typing? Basically, what it boils down to is if you get confused, look at the chart. But nowadays, there's enough blood out there that the blood bank will send either O negative or an exact match for the patient. Coffee, the elixir of youth. No more questions on that before I move on. Ta-dum. Now, there's a couple things when it comes to doing a transfusion. One of those is you have to prep the tubing and stuff for the patient because blood transfusions do not use regular tubing. That tubing that you plug in for giving them normal saline, that's not what you use. The tubing that you use for blood transfusion is called Y tubing. And they call it Y tubing because this forms a big Y right here. You need one line for the blood, and then you need one line for normal saline. The reason for that is you have to flood the lines with normal saline before you begin the transfusion. And when the transfusion is done, you want to flood the lines with normal saline again to wash all the blood out and make sure the patient's getting all the blood they can. It also has a filter to filter out any blood clots or any extra products that shouldn't be there. So you'll hear the nurses say, I need Y tubing, blood tubing, Y tubing. Pretty much the same thing. Now, when you set this up, you're going to put this thing will be empty right here because you won't have the blood yet. So there won't be any blood yet. But you'll take a bag of normal saline and you'll flood the lines with normal saline and you'll hook it up to the patient while you wait for the blood to arrive. When the blood arrives, you hang the blood, plug it into the tubing and get it started, and you're away you go. You'll have somebody show that to you before you ever have to do it. Go back here and finish this up. So you set the tubing up. Once you get the blood product, and this applies to all the other blood products as well, especially platelets, you have to use it within 4 hours. If you let blood sit around for a long time, it can develop bacterial growth, and then you wind up getting an infection reaction in your patient. So all blood has to be used within 4 hours. And there'll be a time on there of when it came out of the lab. So if you look down at the time that it left the lab, and if 5 hours have gone by, you need to call the lab and say, this blood is 5 hours old. Now, normally you're anxiously awaiting it. So as soon as you get it in your hot little hand, you administer it. So that's usually not a problem. Also, red blood cells are big cells. So you can't put them through tiny needles. If they have a little 22 gauge butterfly in their hand, you can't use that for blood transfusion. You have to use at least 20 gauge or bigger. It's preferred you use an 18 gauge. So if you think somebody's going to get blood, try to get an 18 gauge needle in their arm. And like all other procedures, informed consent. Informed means that we've told them that there are possible reactions you can have to blood transfusions and possible risk of infection, i.e. HIV. The possibility of getting contaminated blood is so minuscule today, and I think it's like 1 in 1 million chance that you could get HIV from a blood transfusion. We still have to let them know about that. Usually when you say 1 in 1 million chance, they go, oh, okay. But you do want to alert them to the reactions. So if they get a blood transfusion, then suddenly they start getting pain or start developing a fever, they kind of know what's going on. So there's our blood tubing. Administering the medication, it has to be administered by 2 nurses. Now, it's not within our scope of practice to be the primary nurse. If you're LPN or a practical nurse, you have to have a registered nurse, has to take lead, but you can assist. When you get the blood, you go to the patient with the orders, with the packet of blood, and you're checking the patient's ID. You're going to check the patient's name, medical number, date of birth. You're going to make sure it matches the orders. You're going to make sure the patient's name is on the unit. It may not have the patient's name on the unit of blood. But once you've checked and made sure that you have the correct orders for the patient, you check the blood unit against the orders, making sure that you have the right number of the unit. I'll go back up here. Their RH type is on there, their blood group is on there, the expiration is on there, and identification number. These are all the things that you're going to check against the orders. Once that's done, both nurses sign the orders. We've had some really bad things happen in the past with people getting the wrong blood, and that's why they're really strict about the paperwork nowadays. You're making sure the orders match the patient. You're making sure the blood matches the orders. And they usually have this long identifier number about that long. It's on both the blood unit and the orders. So once you've done all that, you then want to administer it rather slowly. Reason being, if someone's going to have a reaction to the blood, you rather they have a reaction to a little bit of the blood instead of a reaction to a lot of the blood. Now, the exception here might be if you're working in the ER and you have a trauma patient, you have to get the blood into them like right now. And we have blood presses and blood warmers and all that kind of stuff in the ER. But on the floor for a normal transfusion, you want to start out slow over the first 15 minutes. The blood reactions that happen immediately will happen usually within 5 minutes. So if something goes wrong and your patient starts experiencing pain or fever or chills or whatever, you'll want to stop the transfusion right away. After 15 minutes, you're going to check their vital signs, to include temperature, because we're checking for a febrile reaction, which is when your body's immune system kicks in. And then at the half hour after that, there are different policies and procedures at different hospitals, so you'll have to find out how often they want the vital signs taken. But you take them right before the transfusion, and 15 minutes into the transfusion is pretty much industry-wide. After that, they may take it in another 15 minutes, or they may take it a half hour after that. That depends on your facility. It usually take an hour or 2 hours to infuse the whole unit. Any questions on that? Remember, it can be 2 RNs or an RN and an LPN. It cannot be 2 LPNs, or it can't be an RN and a CNA. It can't be. I don't know if a doctor can sign off on that. We've never had a doctor sign off, but basically it's usually 2 RNs or an RN and an LPN. Once it is done, there again, you may have reactions after the unit is finished. So be sure you get a good set of vitals after it's all done. Dispose of the tubing per facility policy. It's full of blood. Some facilities may just have you throw it in the trash. Some may have you put it in a red container. It's all up to the facility. Most facilities, you don't have to put blood in a red container unless it's over a certain amount. So paperwork is important. Make sure all the paperwork is signed, all the T's are crossed, all the I's are dotted. Because if somebody goes home and has a reaction, this is the first thing the investigation is going to look at. Yes, your license is on the line. There can be reactions to the blood. Here's 3 of the reactions. There's a couple more that are less common. I'll talk about them later. But these are the more common ones. Of this is the one that seems to get all the press, the acute hemolytic transfusion reaction. Your body starts breaking down the red blood cells. That's bad. We'll go through each of these. First one, acute hemolytic transfusion reaction. Usually it happens right away. And there again, it's a compatibility problem. You're either giving A to a B person, or you're giving Rh positive to an Rh negative person. Symptoms are chills, fever, lower back pain. That's a dead giveaway right there. They start getting pain in the lower back after you start a transfusion, I would cut it off right away. Tachycardia, flushing, and chest pain. Anyone know why you would have tachycardia? Anyone want to venture a guess on that? When I see tachycardia, first thing I think of is immune system response. When your immune system kicks in, and here you have chills, fever, sounds like immune system, right? It releases hormones that cause you to vasodilate. Your blood vessels open up, causing the flushing. Well, when your blood vessels open up or dilate, you're using a bigger pipe for moving the blood. So your blood pressure drops. And when your blood pressure drops, your heart tries to make up the difference by speeding up. So when we talk about shock in the future, you will see when someone goes into shock, their immune system is sending out chemicals that cause their blood vessels to dilate, which drops their blood pressure. So the heart speeds up to try to compensate. So first thing you do, stop the transfusion, flush their line with normal saline, get it off with it, get the blood out of the line because the blood will clot. And then you're going to take those bags and components, you're going to package them up and you're going to send them to the lab for testing because they want to know why this person had this reaction. If you haven't gotten too much blood into the patient, they can recover from this, but you definitely want to nip it in the bud right away. Next reaction. Febrile transfusion reaction. Now, the name gives it away right there. Febrile, fever. Every time you see fever, you think immune system response. What's happening there is your body is reacting to the white blood cells. What it's doing is it's launching an immune system response. And an immune system response always manifests as chills, fever, flushing, tachycardia, hypotension. There again, all those things that are similar to somebody going into shock. But it's not a really serious one. It's usually a mild reaction. And you just stop the transfusion and it will usually pass. But you won't want to use that blood again. So you stop the transfusion, flush the line out, and give them antipyretics, usually Tylenol. Tylenol is our drug of choice when it comes to fevers, but any of the NSAIDs. Oh, moving on. Have you guys had NSAIDs yet? Do you know what that term is? Are you having, well, you're just starting pharmacology. So I don't know if you've had NSAIDs or not. Non-steroidal anti-inflammatories. That category includes Tylenol, ibuprofen, and aspirin. We call those NSAIDs. And They are good for body pains and fevers and stuff. Some are better than others. I've found that Tylenol is good for fevers and headaches. Ibuprofen is better for body pains and aches. Aspirin's kind of good for both, but we mostly use aspirin as a prophylactic measure for heart, which we talked about last quarter. Those are NSAIDs. Moving on. And last but not least is allergic transfusion. Now, this is just it. You're not reacting to the, it's not like giving A to a B person or anything, but there's just something in the blood that the body does not like. And it's just like going to a seafood restaurant when you're allergic to seafood and having some shrimp. You're going to have a mild allergic reaction, and it's going to manifest with itching, or it could have these, some of these, not all of these, whatever. Urticaria. Urticaria is a fancy name for a rash. So you might get some itching and a rash. Usually the flushing goes along with it too, because of the histamines that are released when you have an allergic reaction. But there's just something in that blood that your body doesn't like, so your immune system launches a response to it. It's an allergic reaction. What you do is you stop the transfusion, flush the line out, and administer an antihistamine. If it's a mild reaction, you just give them 25 or 50 milligrams of Benadryl and it'll go away. If it's a really serious one, the doctor may order a steroid like Solumedrol or prednisone, and those are both anti-inflammatories, and that will make the reaction go away. Treated pretty much the same way you would if you had an asthma patient. Moving on. Boop. Let me. This is a mild allergic reaction. You can have a serious allergic reaction. You may have heard of it before, anaphylaxis. Anaphylaxis is when your body has a serious allergic reaction. Now, the best example of anaphylaxis is people who are allergic to bee stings. When they have a severe allergic reaction, like to a bee sting, you can have things like bronchospasm and laryngeal edema. This is when your throat swells up and you can't breathe. And that is why people that are allergic to bees carry an EpiPen or an epinephrine pin, because you need to get an anti-inflammatory in their body like now, like right away. So a severe allergic reaction could be an anaphylactic reaction, which is indeed life-threatening. Along with that, the histamines being released are causing vasodilation, which causes your blood vessels to open up, causing hypotension. Your blood pressure drops, which could also lead to shock. Shock is when your body is not getting enough blood, and including the brain, and you pass out. I'm not sure when we cover shock, but we will cover shock. But you see the throat swelling up, difficulty breathing, blood pressure dropping, getting all dizzy and wacky and passing out. You may have an anaphylactic reaction, in which case you, of course, stop the reaction, wash the line out so it doesn't plug up, because you're going to need that IV for administering epinephrine. That is measure number 1. You give them a shot of epinephrine as quickly as you possibly can. And hopefully that will stop all this stuff that's going on up here. You can also give them some steroids or corticosteroids like Solumedrol or prednisone. These are anti-inflammatories and they get the swelling to go down, but they don't act as fast as epinephrine. So you definitely want to give them epinephrine. You also want to do some palliative measures like O2, help them breathe better, especially if their throat's swelling up and they're having difficulty breathing. If everything goes totally south, you start CPR, call a code. Hopefully it doesn't get that far. Hopefully. Any questions on that? And it's this quarter. After hematology, we do immunology, and we'll get in the immunology, we get into all the allergic reactions, and we will talk exhaustively about anaphylactic reactions. So you'll get a lot more information on that later this quarter when we talk under immunology. No questions? I'm moving on.
Are we going to be expected to know the different kinds of reactions or just be able to identify the reaction?
That's a good question. There are some signs and symptoms that definitely go along with these. Now, all of them, if we go back, you can see that all of them, will probably have chills, fever, etc. Some of them might be a little unique. For example, rash, itching, those would be an allergic reaction. Or if the person suddenly cannot breathe. There again, I like to test you on stuff that I feel is extremely important. So if you have a patient who's having a blood transfusion and suddenly they can't breathe, or their blood pressure drops to 60/20, first thing I would think of would be allergic transfusion reaction. And what's the first thing you would do? You would run for the EpiPen or epinephrine. Some stuff like that. I'm not going to quiz you exhaustively. I just, pretty much know kind of what kind of reaction they would have to each of these. But like allergic reaction is going to have itching, and allergic reaction will also have the anaphylactic component. You will probably see this again. I'll tell you that right now. But I'm not going to be real picky about, okay, he is scratching his left arm. What kind of reaction did he have? No, I wouldn't do that to you. I might. No, I wouldn't do that to you. Here are some less common transfusion reaction. Bacterial. If you leave that blood sitting around for too long, you could grow bacteria in it. And then you give it to the patient, they are going to have a full-blown immune system response to it, because the blood cells are going to see the bacteria and they're going to fight it.
Bryce?
Yes, ma'am.
If so like when I'm at work, I go get blood from the lab for the operating room and I put it in the blood fridge. So does the 4-hour window is that still prevalent if the blood goes into the fridge while they wait to use it?
What do you put the blood in?
The blood fridge. Does that make sense? I was just wondering if it's still growing bacteria in the fridge.
No, as long as it's refrigerated, you're okay.
Okay.
It's only when it's sitting out at room temperature. But yeah, it's perfectly okay to transfer blood from one refrigerated unit to another. Bacterial infection, you're going to have a reaction same way you would if, say, you had a wound that got infected. Your white blood cells are attacking the blood because they see it. They're attacking the bacteria in the blood. But this is rare because usually we don't leave the blood sitting out that long, or if we do, we don't use it. But wheezing and chest tightness and hypotension can be some of the symptoms you would experience with a bacterial transfusion reaction. This would usually happen sometime after the transfusion because it takes time for your immune system to react with that type of reaction. And hopefully, if it's detected, if the bacterial infection is detected, we could administer antibiotics to stop that reaction. Last but not least is circulatory overload. That's just when we put too much blood in too quick. Usually this will happen maybe in the ER if they get a little over anxious. Basically, you're overloading the heart with too much fluid. And it's usually not just a blood transfusion. It's a combination of things. You know, the medics gave them 2 liters of normal saline before they got to the hospital. Then we gave him another unit of normal saline when he got in the ER. And now we're giving him blood. So now he's loading up on like about 3 liters of fluid in his body. and it started to get to be a bit too much, at that point, we just stopped administering the transfusion. And we put the feet below the heart to hopefully let the fluid go down in the lower part of the body so you're not overloading the heart. They may get some diuretics or something like that to help them get rid of the fluid, but basically we just kind of wait and let the body process it out itself. A good indication will be that the blood pressure is going up. And say, wait a minute, this blood pressure is higher than it should be. So something you would consider if you're doing circulatory overload. That, like I said, that's usually in the ER that you'll see that type of thing. Any questions on packed red blood cells? That's mostly what you're going to be dealing with. I'm just thinking of that TV show that was on television where the vampires kept raiding the blood banks. I can't think of what it was, but anyway. This is probably the second most common blood product you will administer, fresh frozen plasma. And basically when when we showed you the tube that went through the centrifuge, that clear stuff at the top of the tube is all the plasma. They separate that out, pack that separately, and they freeze it. And that keeps them well, preserves it. I think they put a little preservative in it too, but I'm not sure. Mostly we use this for patients. Now, we all know what platelets do, correct? Platelets go to the site of a wound and they help bind up that wound and clot it until your body's natural growth processes grow the vein or the skin and stuff back over the site. So it's kind of just a temporary clotting while your body's tissues regrow and plug off wherever the bleed is taking place. It's to keep you from bleeding out all over the place. Hemophiliacs are people that don't have the right clotting factors in their body. So once they start bleeding, they just keep bleeding and bleeding and bleeding, which means they have to be very, very careful. Usually when I've given fresh frozen plasma, it's usually been after somebody has had at least 3 packed red blood cell transfusions. Because you think about it, we're giving the person more and more red blood cells, but we're not replacing the clotting factors. So the more red blood cells we give them and the more normal saline we give them, the more we're diluting their bloodstream and the less concentration of they have of the clotting factors and the platelets. So by putting the fresh frozen plasma in there, we return the ratio of the plasma to red blood cells back closer to normal. Otherwise, the person becomes the term for when they have too many red blood cells. And I can't think of it right now, but anyway, I'll think of it probably after we stop. But you get too many red blood cells in your body and not enough plasma and not enough clotting factors. There's a lot of stuff in that plasma, so we have to restore that. Also, we might use it if they're undergoing surgery and they might be a lot of bleeding expected. So usually about every 3 transfusions of packed red blood cells, we'll give them a fresh frozen plasma. And that raises their clotting factor or their PT and their PTT by, I think it's PT that raises here by about 2 or 3%. Important thing, they use a filter. You always got to make sure before you give the plasma that you use a filter. You'll find these in the storage room. Platelets. Platelets is another one. We'll usually give them plasma before we give them platelets because the plasma has more of it has the clotting factors in there as well as the platelets. So it's a better full package, so to speak. But if they know somebody has a particular type of deficiency, they might give them just the platelets. And those are usually genetic disorders, which we'll talk more about when we get to that under immune system. One of those is factor 3 deficiency. When we get to an immune system, you will see that there's for somebody's blood to clot, there's this whole cascade of processes it has to go through. It's a chart about this big. And there's a whole lot of factor 1, factor 2, factor 3, factor this, factor that. And all of these have to fall in place in order for the blood to clot properly. And some people are genetically born, they're just not producing one of those factors. And that presents clotting problems. So there's a variety of medications and stuff we can give them to help fix that. But every once in a while, they might need platelets as well. It uses the same filter as fresh frozen plasma, and like blood, make sure you use it within 4 hours. Any questions on those before we move on? Pretty simple. Whole blood. This is where we take the whole blood and put it in a bag and keep it. We don't use that as much. In fact, I can't remember when I've given whole blood products. So it's rarely used. We don't use that much. The reason being is because usually when we're giving somebody a blood transfusion, we're interested in increasing their red blood cells, not all the other stuff. So we'd rather have the concentrated red blood cells so that we can improve their oxygenation as quickly as we can. And everything we do in medicine is to get oxygen to the brain. I mean, CPR is to get oxygen to the brain. Blood transfusions is to get oxygen to the brain. You got to keep the brain alive. You lose the brain, you lose everything. So that's what we're really trying to do, is increase their oxygenation by giving them a blood transfusion. So we don't want all the other stuff, because all that's going to do is just volume overload the person. So that's why we use the RBCs more often than we use whole blood products. Any questions on any of the stuff I've covered? How are we doing for time? Yeah, we're doing pretty good. Try to get down to a half hour, but it always ends up being an hour anyway. No questions?
I have a question.
Sure, go ahead.
Not a question per se. For the NSAIDs, you say Tylenol is an NSAID, or is it just acetaminophen? I don't think it's an NSAID.
What is that?
Tylenol.
Tylenol, I think Tylenol is an NSAID. Non-steroidal anti-inflammatory. I'll have to look that up.
I don't think so.
Okay.
I saw like it's a non-aspirin.
Yeah, aspirin and Motrin, but I thought Tylenol, acetaminophen was in that group as well.
Okay, I'll just.
Let's look that up. What are NSAIDs? Examples. Ibuprofen, naproxen, aspirin. Oh, you might be correct. Yeah, I don't see acetaminophen in there either. Oh, you're right. Good job. I always thought Tylenol was an NSAID. Okay. I stand corrected. Actually, I'm sitting corrected. I'm not standing.
It's okay.
Any other questions? I'm sure that Chuchi is going to hammer you with NSAIDs in pharmacology.
I have a question, but it's not about the material.
Okay.
Do you want me to?
If it's not about the material, let's wait until I stop the recording.
Sounds good.
If there's no more questions on the material, I will stop the recording then. Bye-bye, everybody out in TV land.